Okay. Let's see. Aha. Great. Well, thank you. Good afternoon. So it's my pleasure to give this brief update on the activities of the LUGPA Benchmarking Committee regarding the active surveillance project. I do want to thank, again, at the outset, Genomic Health for their very generous unrestricted grant that has made all of this possible, as well as LUGPA leadership and all of the sites that have participated in this effort. I'm going to start, before I get into some of the results of the work we've done, I want to start by taking a little detour back to give some perspective on this type of research and I think how it fits into the greater research world. So specifically, I wanted to talk a little bit about this term practice-based research, which was promulgated in 2007 by this notable JAMA paper, from which I borrowed this figure. And this figure is sort of a roadmap, if you will, of knowledge as it's generated from bench research and then transitioned into at the bedside, and then from the bedside into clinical practice. And the reason why this paper was notable enough to get into JAMA at the time, I think, is because of its focus on the second half of that journey from bedside to practice, which I think commonly had been assumed to happen naturally. Once the paper comes out, doctors read it, it's implemented. And obviously, as we know from 30 plus years of health services research, that's not always the case. And so this paper coined this phrase, practice-based research, which really focuses on the right side of this journey and is designed to evaluate and describe and share the insights into how healthcare delivery and how they help with quality of care, the implementation of clinical guidelines. And so the 2 points I want to make about this are, number one is I think that LUGPA practices kind of own practice-based innovation and really have dominate and define a lot of the innovation in urologic care delivery that I've seen in the last few decades. And LUGPA itself, I think, has done a great job spearheading several efforts that kind of circle around practice-based research, including, obviously, the effort that I'm going to talk about here today, but also the work with measure development that we did, and then the practice management benchmarking efforts, and then also the alternative payment model work, which we heard about earlier from Gary. And so this is all fantastic work, but I would argue that we, as a group, are still leaving on the table a lot of untapped territory in terms of applying the tools of research toward the innovations that so many of us have undertaken in our practices, so that we can both evaluate them and participate in this national intellectual discussion about healthcare delivery, which, as we will talk about after my talk, and as you are all very aware, is a critical component of healthcare delivery in this country. Policy drives much of what we do, so I believe that it's exceptionally important to boost our intellectual footprint, highlighting some of the stuff that we've done to innovate in care delivery. This is just a silly diagram that I made, but essentially this point that on a local level, LUGPA practices, I think, are primarily involved in economic and reputational competition in their local marketplace. But while we're doing that, we are all collectively contributing to this intellectual discussion that really is aimed at public opinion and then policy. And the advocacy work that we do is unparalleled at LUGPA, I believe, in urology and many medical specialties. And I think practice-based research is the perfect research adjunct for it. And so I want to talk briefly about this one paper that I've talked about before, and I think most of you know of, to highlight two of the real benefits to practice-based research. And this is this paper that came out in 2014 or 13, looking at urologists' utilization of radiotherapy and documenting an increase in the use of radiation among urologists that had combined with radiation oncologists. And there's two things I want to say about this. Number one is methodologically, this research used claims data, Medicare claims data, to document that increase in use. And then based on that, sort of went on to conjecture some reasons why that might be, and even to suggest or imply some policy solutions, perhaps not allowing urologists to self-refer, going back to the importance of policy in healthcare. But also, you know, in my opinion, this is fine and it's interesting research, but it doesn't really answer the question that we need to know, which is it good that that many people are getting radiation, or is it bad? It just says there was more. Are we correcting a problem, or are we creating a problem by doing this? And this is where I think practice-based research comes in, right? It's working with groups to get the data that you need to answer the questions that matter about healthcare delivery. So that's kind of the milieu that the benchmarking committee entered into, or came out of, if you will. It's formed in 2013 with its objective to understand and improve quality of care. And in 2014, we underwent the effort, what's now come to be referred to as the Active Surveillance Project, which was to evaluate the use of active surveillance and management of incident prostate cancer among the participating groups. And these are the participating groups, 9 groups, about 250 urologists, 8 states, and these are the physician leads and champions at these groups, who are obviously critical in making this all happen. And I would just add that the only reason there were not more groups in this study was an issue of bandwidth and funding. But it does highlight that I think there's tremendously more potential than even this with a more organized effort. So why did we pick active surveillance? Just briefly, because it fits on this journey of knowledge perfectly, in that there were guidelines for active surveillance, the safety was established, guidelines were in place, but the implementation into clinical practice was not perfect. And these are some of the numbers of papers that were out then. And by 2013, 2014, we were seeing something like 50% adoption, and then 73% in Sweden, which I think is the highest number that's been published so far for that era. So we conducted this 2-phase retrospective study. In the first part, we were looking at the initial management of prostate cancer, retrospective chart review done by the practices, abstractors trained by me, looking at disease diagnosed in 2013 and early 2014. And then the second part was looking at the cohort of men on active surveillance from that period and following them for the next, so far, 3.35 years is how long we followed them. And this was limited to intermediate, low, and very low risk disease in men under the age of 75. And so for phase 1, we ended up with over 2,000 men with incident prostate cancer. One little note that 16.5% of them were African American, which is a nice racial distribution among the group. In phase 2, we took the 557 men who were on active surveillance and then followed them up. And for this part of the study, we broadened our demographic data to include stuff like insurance status, comorbidities with a structured assessment tool, genetic testing results, and a bunch of other clinical data points. So I've presented this before, although this is a slightly updated and refined slide. And I don't have time to go into all the cool data, but this is one of the fun ones. This is the phase 1 outcomes. It's looking at the use of the primary therapy by NCCN risk group for men diagnosed with prostate cancer in 2013. And what's notable is that men with very low risk disease, 75% of them were put on active surveillance. And this is in 2013, which is in a way a long time ago. 44% of men with low risk disease and 11% with intermediate risk disease. This is kind of what we would expect, although from a 2018 standpoint, I think we can all see that there should probably be more men in the very low and low risk group on active surveillance. But this is higher than anything I've seen from that same era. and I think is a testament to what happens when urologists practice care in an organized large group setting. And then the use of surgery and radiotherapy there in red and green, you see a slight preference for surgery, which is interesting given the prior paper I talked about, but also there's no statistical difference between surgery and radiation across these groups. So when we looked at that question further, use of surgery versus radiation, by practice, this graph has the estimated probability that a patient in each practice would choose surgery or radiation. And the line across the middle at 0.5 is roughly a 50-50 chance that they'll do one or the other. And that's probably where it should be, at least based on the data, which is equivalent for use of surgery or radiation. Although there are all kinds of factors that could push a practice one way or the other, like the presence of a superstar radiation oncologist or a superstar robotic surgeon could potentially sway things a little bit. But we would expect practices to be basically in the middle, and I think we see that here. We see that a majority of practices, men got essentially a 50-50 chance. There are a few practices that are outliers, and that's a super interesting topic that I could go into more, but I will say anecdotally, I believe that it was driven by this effect I talked about earlier of having a sort of a superstar physician in one or the other specialties, either in the practice or locally. So phase two. I want to start this discussion with this slide because to me this just highlights the amazing potential of LUGPA groups to come together and do real research on practice delivery. This slide compares the major academic active surveillance cohorts, which, essentially all of the papers on active surveillance that defined it as safe and effective, et cetera, were done in these cohorts. And then we have the LUGPA active surveillance cohort. And a few notable things. Number one is the size of our cohort is kind of in the middle. I mean, it's low, but it's not the lowest. It's competitive. The time period over which those men were enrolled is extremely short. Most of these enrolled patients over 10 to 20 years. And we enrolled almost equal number in essentially 1 year, plus some change. Age is the same. Median follow-up, also not bad at 40 months. On the lower side, but well within the sort of range that we see here. And then the conversion to treatment, or the number of men who came off of active surveillance during our follow-up period, is also basically par for the course, 32% in our group. And then we have reasons for discontinuation there. So to me, this just highlights the potential in a short period of time to come up with a truly academically relevant and competitive cohort of men. And the possibilities, the opportunity to use this group to understand and refine our understanding of how to manage men on active surveillance are relatively limitless. So again, 557 men, follow-up at 3.3 years. 11% of men were lost to follow-up in this time period, which to me is amazing. It means 89% of men who were diagnosed in 2013 continued to get their active surveillance care in their diagnosing practice. I would have thought it would have been a lot higher for a community cohort, not a part of a study. People move for all kinds of reasons, insurance changes, but that's remarkable. About 57% had a repeat biopsy. Probably could be higher, but not bad for having no protocol. 25% of those people had disease progression, which is about what we see in other academic studies. 32%, as I said, underwent curative therapy at a mean time of 21 months. And again, if you look at those guys who went on to curative therapy, equal distribution between radiation and surgery. And I might add that all but one of these practices did have radiation as a part of the practice. And then about a fifth of men had genetic testing. And so here we look at this Kaplan-Meier curve of adherence to active surveillance by NCCN risk group. We see a statistically significant prediction of adherence, very low risk in blue, low risk in red, and intermediate risk in green, which in and of itself is not new knowledge, but this is real-world evidence. And it's remarkable to me that without a protocol for active surveillance, without centralized path review, without a common definition of which is the diagnostic PSA, we still see that NCCN risk group functions well. So that's the kind of stuff that real-world confirmation that you can get with practice-based research. If we look at race and ethnicity, which we don't want to see influencing treatment decisions, we see here that black and white men had no difference between them. This other group is too small to really draw conclusions about it. And if we look at genetic testing in relation to adherence to active surveillance, this is also kind of a hypothesis-generating number of cases here, but we see one trend, which is that men with genomic tests that suggested more advanced disease dropped out of active surveillance much more commonly than other men, suggesting that doctors and patients are listening to genetic tests or trust in the results. I'm going to skip this, and then I just want to quickly run over some of the things that have come out of this work. We have 3 papers, 2 of which are under review. I was hoping they'd be published by now, but there were lots of hurdles. Third one is almost out the door. We presented 2 abstracts at the AUA based on this, one of which was selected for Media Day and generated some amazing press in Urology Times, which I'm sure everyone reads, and Renal and Urology News. And then we had a poster last year on the active surveillance cohort follow-up. We've talked about this at multiple LUGPA meetings. And then, so moving forward, I don't know whether this is the end or the beginning, but it could be either one. I personally hope it's the beginning of more work. I think that there's a role for a broader and increasing LUGPA Health Services-oriented research effort. Lots of different topics and questions that we could look at, some of which are here. Study leadership of this, Neil Shore, relatively little poorly known urologist that practiced in South Carolina. And then the other people here, Tom Pivanis, study management. So thank you again for the opportunity to do this work, and see you next time.